Next speaker is Mr. Usman Khan. He's a consultant surgeon and director of planned surgery at East Cheshire. He will share his experience of treatment of malignant conditions in elderly. Thank you very much.
Hi, Assalamu alaikum, good afternoon. Actually, this was submitted as one of the short papers, and then Sohail was very kind, he wanted me to present it here. So, how many of you use enhanced recovery after surgery? So few. Okay, right. So, it's a small introduction first, and then I'll, let's see, how does it work? Right. So, actually, this was started by Henry Kellett, who is a general surgeon, gastrointestinal surgeon in Denmark. And he started this, but he was doing it in open colorectal surgery. So when in Britain the laparoscopic colorectal surgery started, so we thought that if we are doing it through an incision about the size of an appendix is going home in first or second post-operative days, so why can't we apply that to the colorectal cases? So if you look at this photograph, the one on the left is open interior resection, and one on the right is laparoscopic, and that's from where the specimen is taken out. So this guy would go home normally in 3-4 days time. So what is enhanced recovery? Actually, it's a peri-treatment protocol which consists of several steps, and so that patient can go home early, and it would have a cost benefit effect on NHS. So we reduce the length of stay. The complication rates after major colorectal surgery are reduced, and but the most important thing is without compromising patient safety, because Henrik Kellett has, although popularized this around the world, but he never told us that his readmission rates were 25%. Our readmission rates in UK are about 3% after enhanced recovery, because he was sending his patients home on the first or second post-operative day. There are 4 elements to the enhanced recovery program, in which there is a very detailed pre-operative assessment, planning, social workers are involved. Then we reduce the stress of surgery by short-acting anesthetics, avoiding fluid overload, pain relief, laparoscopic surgery, and structured approach to the post-operative pain relief, and of course early mobilization. So the benefit to the patients are shorter hospital stay, so that avoids the risk of nosocomial infections, ability to return to their own environment. Most patients are keen to return home at the earliest opportunity, unless their mother-in-law stays with them. And benefits to the hospital, of course, better use of beds, ability to accommodate more patients, and avoid complications or extra expense due to the nosocomial infection. The longer the patient stays in the hospital, they're more prone to infections. So we looked at this is the picture of the East Cheshire NHS Trust. That's the hospital. It's a beautiful part of the country. And that's the pond here. We have ducks there, but all those ducks are dying because of lung cancer. And whenever I do my ward round, I say it loudly, so that all these patients who go and sit here and smoke in this pond, and that's obviously affecting the ducks anyhow. So colorectal cancer, as we know, is the third most common cancer in the Western world. In UK, 40,500 patients will have colorectal cancer every year, and more than 16,000 will die. Lifetime risk of all of us is 1 in 19, all of us who live over here and consume diet over here. So what's our protocol? We put them on low residue diet low residue diet for 2 days. They are able to take all the carbohydrate loading up to 4 hours, and they will take oral fluids, clear fluids up to 2 hours before surgery. We don't give them any bowel prep. Low anterior sections will only have a phosphate enema. They all take a Hibby scrub shower before surgery. And post-op, of course, if it's an open resection, they'll have epidurals or patient control anesthesia. But for laparoscopic surgery, they may just have oxynom tablets, codeine, or maybe tab block. And we take the urinary catheter out on the second post-operative day. But the most amazing thing of these cases are the next morning when you come to the ward, you see them sitting out, having breakfast, and pain-free. So the group consists of consultant surgeon, anesthetist, pain team, dietitian, pharmacy. There are a lot of people involved. Regular meetings, 4 monthly and policy reviews. So so we looked at our patients from 2008 to September 2017. The hospital covers about 450,000 population. And actually there are 3 dedicated colorectal surgeons, not 5. So if you look at it, 629 patients went through ERAS, enhanced recovery after surgery. The data shows that there is no difference in age, ASA grade, BMI. Elective laparoscopic were 424 and open were 205. Outcomes. The operation time is obviously a bit longer for laparoscopic surgery, but there was no difference in lymph node harvest. Length of stay is noticeable. There's a difference of 5 days. That is statistically significant. Survival, I think that's probably based on the case selection. I don't think ERAS will actually make a difference in their survival, or it may does. Probably more trials may say that it does, but I'm not sure at this stage. Length of stay, as you can see, ERAS versus conventional care, there's a difference of 5 days. Complications again are the same. There is no difference. The highest is ileus, which I failed to understand actually why after laparoscopic surgery, but you usually see them after right hemicolectomies in laparoscopic surgery, because probably we dissect in the area of stomach, so that causes ileus. I've been unable to work it out, and I've spoken to a lot of colleagues, even from St. Mark's, and there is no explanation for that yet. The next is hospital-acquired pneumonia, wound infections, obviously the common complications. So there were some patients who we had to take them off ERAS. Those patients who had any cardiac events or hospital-acquired pneumonia, leaks, large abdominal collections. So in the end, deviation from ERAS resulted definitely, the studies show that in delayed hospital discharge, obviously, and they were either due to the medical and surgical causes, and early deviations were mainly due to the anastomotic leak or small or large bowel obstruction. What we also saw was that the patients who came from poor socioeconomic background, ERAS, we were unable to apply ERAS so well in that, because due to their home conditions, they were not able to go home early, and they stayed on in hospital for days or weeks extra in spite of being on ERAS. That's the last slide. Is there any time left? No? Okay.
Sorry for that.
No, it's fine. I had a video also, but we don't need to see that. Right.